I now invite the panelists to take to the stage. I invite Dr. Narendra TAJNE. He's the airway anesthetist, pediatric airway anesthetist here at Child's Trust Hospital. Absolutely cool-headed even when the saturation is down at 0. And Dr. KAALAN JOHNSON is known to us. And Dr. Thiru will take Dr. Shashidhar's place on the panel.
Very good morning to all, and good evening or probably good night to Dr. Atter and Dr. KAALAN. And thanks for staying with us such a late night. I met Dr. Atter in Genoa first time, and I heard when we and Thiru went there. So we met first time, but I think I consider Dr. Atter as one of our team member, not from the Cincinnati. Like, he's from Cincinnati, he is having his own team there, but he is one of our team member, because at every stage we have done the same thing. If we are having any doubt, we'll take a video, we'll send it to him, and he will immediately, whenever possible, he'll reply to us. Thanks for that. So Ratter has spoken about a very elaborate talk, and I don't think anybody is having any doubts. And I don't know what I am doing here. Ratter's student has spoken about the Indian experience also. So I don't think much to be done here for me. I just wanted to ask Dr. Ratter. I understood that you are doing he is in favor of the open surgeries, and he is doing most of it at the late stage. I just want to know whether you are doing it single stage or double stage. Dr. Ratter?
So if we've got a child who presents to us with a congenital laryngeal web and doesn't have a trach, but does have airway symptoms, we'll usually repair them single staged, and typically it's a relatively short-term intubation most of the time. If they've already got a trach, then we'll delay it and wait till they're bigger. If they've had other things done, so if someone's tried to divide the web with a laser, then usually again we'll wait and do a reconstruction that involves a keel at a later date. But so it depends on the child a little bit. And thank you very much for the kind words, and also thank you very much for that very impressive presentation on what's happening at India with blotted webs. Appreciated.
Thank you, sir. It's Dr. KAALAN. Can you share your experience? Like, specifically, I think everybody is knowing type 1, type 2, we are managing endoscopically or thing. What about type 4 web? Do you do any retrograde scopy if you have a tracheostomy, or do you rely on the radiology for the subglottic extension and seeing how is the subglottic part?
I think, the numbers of these cases are obviously small, but I was just talking to Dr. Rutter, as you guys do as well, about a case that we saw earlier this year. I think, in my experience, in my opinion, I'll take all the information that I can get. So if I can put a 30-degree scope through the stoma and see anything looking up, then I will do that. But the radiographic imaging is often the most useful component of that evaluation when you're trying to see the thickness between the larynx and the trachea itself, and the trach tube itself in the stoma.
Okay.
The other thing I'll just suggest, if you have a siloendoscopy scope, the semi-rigid telescope in a siloendoscopy scope is 1.1 millimeters, and that will get through even a very small stenosis. The optics aren't perfect, and it's a very difficult thing to use doing a bronchoscopy because it's just waggling everywhere, but it will go places nothing else will go.
And if you don't have that, the pediatric endotracheal tube stylets are also a really nice option. I learned the part that you put in generally to intubate with the endotracheal tube is really floppy. So turn it around backwards and it's a more rigid instrument if you need to palpate. That's about 1.2 millimeters, I believe.
Can I have my slides? Okay. So I think they have already spoken about why not, like everybody is speaking about the thing, why I just wanted our experience also here. So I try to go very fast. This is whatever the classification we are classifying, and depending on that one we are deciding on the treatment. So our data, talking about our data, we have total 18 cases, all congenital laryngeal wave cases. As already discussed, type 1 were either observed or simple wave release were done. Type 2 cases, we had a keel place after endoscopic steel release. Now coming type 3 waves, we have 3 patients with the subglottic extension, and they were managed with the LTR. But 2 patients we have without subglottic extension, and they went open approach for the keel placement. So type 4 waves, as most of the people, or Dr. Anju is selling a double stage LTR. But we have one case which presented to us quite late, at almost 2 years, 1 year, 8 months, and we did a single stage laryngotracheal reconstruction and keel placement. I'll try to skip things. I think everything Dr. Atter has shown the videos, everything. So I just to keep in time. So this was an endoscopic for the type 2 wave surgery and keel placement. So yesterday we have shown also probably keel placement, and I hope everybody got the what we are doing. Everybody understood also. So this is a 3 months post-operative, same patient after after releasing web, and so its airway is looking quite good. So coming to type 4, I have just skipped the type 3. This is the type 4 wave we have. We got it. This is the case I was talking about, where he presented late, and we did a retrograde scopy to know how is our subglottic part. So to take a decision for the next treatment, and we had a radiology, we see for any soft tissues, anything, and we went ahead with the open surgery. So anterior graft was placed, and we have induced this child. We have, as anesthetist, it will be unfair if I don't talk anything about the anesthesia. So we have, being a small thing, we have put LMA in this patient. We have used the supraglottic airway. We have maintained neck was open, and we have done the scopy through the LMA bronchoscopy. So to guide the surgeon, so to the superior part, we have done the scopy, and we have after this one, because we have planned for the single stage and we don't want to place any stent, so we have placed the keel, and the keel placement was guided by the bronchoscopy. And after placing keel, we have intubated the child with a smaller size we have intubated nasotracheally, and we send the patient for ventilation, elective ventilation. This is the graph placement and all. I'll try to skip. So talking about this one, the same patient, as I told you, we have we have used only this. I wanted to just highlight about my anesthesia technique also. That's supraglottic, how supraglottic airways, they are useful. So we have put this is Prosil LMA, and we put it Prosil LMA. We have maintained with that one, and as you can see in the next this one, the same airway, supraglottic airway was used for doing bronchoscopy to guide surgeons during the procedure. So again, making sure that we are also there in the team. So this is a 6-month post-operative. Anterior graft looks, it's good. It is taken well. Mucosa is looking good. So coming to type 3, this is one of the type 3 web. What we have done is open keel. No, we have opened. See, because we are not able to see the web exactly how much length web to cut. So we are opening the neck. We have open keel. We are releasing this one and putting here again. Same. We are intubating with the LMA, and we are doing scopy to guide them for the web. And it's just opening, releasing web, and this one. So I don't know if other people also doing this. I'll probably from the other panels also like to know. This is the 6 months post-operative. I'll just go a little fast. This is another one, web 3, type 3 web, soft tissue radio. This is the endoscopic vision. After putting that, putting the releasing web and putting a keel as an open keel. So we just make sure where it is sitting, and we are doing the scopy from the up, just to check the position. So yesterday, as we have seen the keel, web release, same procedure what we have demonstrated yesterday. So we have done again here the laser. I think again I can skip this. I don't conclusion. I think probably everybody has to conclude only. I just wanted Dr. Anju. What about your experience in open keel placement, open web release?
So instead of a keel, we have the LT mold. So we would prefer using it because it gives an excellent anterior commissure formation. And we also introduce an endoscope if we are not able to initially, when we try to open, if we are not very sure whether we are in the midline, then we would ask the anesthetist to introduce a flexible scope through the nose, and they will guide us where we should cut the anterior commissure, because it's most important for voice to keep the anterior commissure in midline, cut exactly in midline. Sometimes we can also start superiorly if we don't have to use an endoscope and we are lost, then we can start from the thyroid notch and start cutting from up to down. Then we'll most likely be in the midline. After cutting, we can pass a mosquito superiorly and spread the ala apart, and that will guide us to keep us in midline.
Dr. Thiru?
Yeah. Actually, we have presented two places in India about our experience in web management. Most of the things are being followed by either Professor Philip Monier's book or the latest incorporation of ideas from Cincinnati group, mainly from Professor Ratta. So generally, what we are doing for 1 and 2 is going to be the same, and 4 is also almost like going to be the same. The difference in the management comes only for type 3 webs. That means when type 3 webs, whether there is any subglottic extension or not is the question here. If there is subglottic extension, what we are going to do. If there is no subglottic extension, what we are going to do. There are two different school of thought. One is, if there is no subglottic extension, you can do a endoscopic repair and keel placement like for type 2 web. And then in type 3 webs, if you are doing a open surgery, there is an advantage of having the mucosa coming into the anterior commissure, suturing it like how Professor Mike explained in his talk. So that is an advantage, so that we can have a good anterior commissure in open web instead of doing a keel. So here in our experience, what we did was, we had the situation like where the child came at 2 years, undiagnosed for 2 years, with the web and subglottic extension, like what we saw. So if there is a web with subglottic extension, then the usual thought would be put a graft and do a double stage procedure. But here we didn't want to do a tracheostomy because already the child is 2 years. We straight away went in for a single stage procedure. So what we did was, we put a graft, and for the graft we have intubated the child so that the graft will be taken care of by the endotracheal tube for a week. But what happens after 1 week? Maybe we need to have a keel also to be there in between so that the anterior commissure will not get closed. So what we did was we put an endotracheal tube. On the sides we kept the keel. So for some time the keel will be there for a week. After 1 week we removed the endotracheal tube and kept the keel for 1 more week, and then we removed the keel. That's what we did in this particular case, and luckily that case came out to be very good. So what is your thoughts on that, Professor Mike first, and then Kalen next?
I'm just, firstly, as a random comment, having a good anesthetic team is absolutely critical if you're going to do airway surgery, whether it's endoscopic or open. And so, again, you're very, very lucky to have such a good anesthetist. Thiru, I'm afraid an awful lot of what you were saying was breaking up for me. And so I think the last thing I heard was if you're doing a single stage procedure and you're leaving in a keel with an endotracheal tube beside it, that you could extubate but leave the keel in for longer than for an additional week. And I think I completely support that idea. We've actually just done a child a month ago using that technique. And so I think that's a very useful thing to do. I would also note that with particularly DeGeorge syndrome, you can get a surprising amount of subglottic swelling and glottic swelling for a while after a reconstruction. And so single staging the DeGeorge kids is a bit more challenging, even if you do it open and eventually you take a suprastomal stent out. They can still remain relatively swollen for 6 months afterwards. So it takes a long time till you finally know what you've got. It can take a long time to settle down, but you may see improvement for quite a while. Kalen.
Yeah, I agree. I caught about 25% of what you were saying, Peter. So if you want to step to the podium, if you have a more specific question, I think Mike and I would hear you better from the microphone at the podium. So yeah, after Dr. Rudder and 2 different centers of Indian experience, I don't think I have a huge volume or amount to add to the conversation, but I do think that I would just echo what has been said about preserving the mucosa when possible in patients who have not had previous procedures. And I would just echo that in saying that my own experience being someone who does a lot of endolaryngeal suturing and deciding that I wanted to test what I'd been taught and try to, suture some endoscopic mucosal flaps here and there. The airway works great, but I still feel like I haven't gotten the voice outcomes with endoscopic procedures alone for suturing mucosal flaps that I would like to get. And so I'm back to subscribing to the philosophy that a laryngeal fissure and virgin mucosal flaps pulled anteriorly would be the best way to go for that.
Okay. Thank you very much. I think that was a real wonderful session, and hope we learned about all those congenital anomalies also associated. We'll also try to search for that, and I hope that high airway obstruction will not get and will not cause chaos in our life at least. Okay, thank you very much.
Thanks a lot.
Thank you very much.
Thanks a lot, Professor Mike and Dr. Kalen. Kalen will be here with us for the rest of the sessions. If you want, you can also be with us and give your comments, during the next discussions.
We can't hear you, Thiru. We can't hear you with that microphone at all.
So go to the podium.
The podium microphone is working well, and that's the only one that we can really hear very clearly.
Yes.
Hello. Yeah. Able to hear me now?
That's great.
Yeah.
Oh,
Yes,
so much
now we
better.
can hear you.
Yeah.
Thank you.
Yeah. Okay. So thank you. Thank you, Professor Mike. What I was telling is Dr. Kaalan is going to be here with us. He's been here with us for the past 3 years, though it is midnight or early in the morning, whatever it may be. There is no time difference here in this conference. So wherever you are, across the border, transcending border, we are conducting this conference for the past 2 years. He was here with us for all the
2 days, you mean?
Yeah, 2 days with us for all the endoscopic live sessions, procedures. He was giving his comments and whatever the plans for the future surgeries and everything. So what
No
we
pressure,
request is
Mike.
you
Theodore, that was partially because you kept giving me the last talk of the conference.
okay. Anyway, thank you. So, if you want, you can also continue to be here and online, Professor Mike. So that is the request. If you like to do it, thank you so much.
So thank you very much for the invite. I hope the rest of the day goes very well. And unlike Kaalan, I need my beauty sleep. He's young. He can cope. I'm much older than he is. So I'm actually going to apologize. I'm going to go to bed. So have a very good meeting.
Thank you. Thank you so
Good to
much.
see you all again.
Thank you
Hey,
so
Mike.
much. By the way, you don't look that
There you
old.
go. Mike, can you hear me?
Yes, I can.
Oh, you mentioned the kid that we had talked about earlier. So I gave an update to
yeah.
Peter recently. So I thought I'd just
Sure.
thanks. And it was precisely what you were talking about with this bilobed cricoid that you kind of see the misshapen, really weird looped up cricoid. And then kind of separate from that, there was an upper cricoid as well that the posterior graft sat between for an extended partial cricotracheal resection. And so this was the larynx that we also divided endoscopically to try to get as much of an endoscopic assisted laryngeal fissure to get that in the midline as we went up. But he did well post-op, and the stent was in for 3 months, and then he developed some erosion of the suture through the skin. So they actually took it out earlier than we were anticipating to leave the stent in. But we have one video so far. I haven't seen a follow-up after this was at the time of stent removal. So I'm sure it'll look worse, but hopefully stabilize. Their goals were speech, and so we're hoping to at least be able to get that. So thanks again for your help
That's
on
great.
that. Everyone around the world with these things.
Take care, guys. Good to see you all again. Bye-bye.
Thanks, Mike. Take care.
Thanks, everybody.